My name is Wolf Armbruster.
My name is Rüdiger Eichholz.
And I'm Thomas Notheisen.
And our subject today is
needle tip control in ultrasound-guided interventions and procedures. So mainly we're talking about ultrasound-guided nerve blocks and vascular access.
You see three speakers here because we are doing a lot of ultrasound courses together.
Why do we recommend to use ultrasound in invasive procedures? We all know the cases with landmark vascular access, with difficult situations where we have displacements of catheters as shown here. Or in this photo you see a lot of catheters, and the one in the middle with the red tags obviously has a little bit of an unusual position on the lateral side of the clavicle. And if you look at this on a chest X-ray, you will find the ultrasound guided placements of two catheters, the blue ones and the displacement of the red one, which was placed in the subclavian artery in an emergency situation. So nobody tells that using ultrasound reduces complications as such. So we need to have some ideas how to really master this method professionally. So what do we need? We normally talk about three pillars as preconditions for safe and successful ultrasound guided procedures. So the first one is basically probe maneuver. So we need to know and to practice how to handle the probe, how to get what we want on the ultrasound screen. So how to get the target structure. And the second, what we need, the second pillar is sonoanatomy. So we need to have a deep knowledge of what we are looking at. And the third thing, and this is going to be the major thing we are talking about today, this is needle tip control. To start with, we go over some basic information so that we know what we're talking about within the rest of this webinar. So we look at the lateral neck on these two videos here, and the anatomical structures are shown in a transverse cut, which is also known as short axis. So the other term we need is obviously a longitudinal cut or long axis, which is shown here on a radial artery on the mid-forearm. And in contrast to this, what we call axis terminology, we talk about planes. Planes refer to the needle guidance in relation to the scanning plane and not to anatomy. So the axis terminology refers to anatomy only, and the plane terminology refers to how to guide the needle into the scanning plane. And this shows an out-of-plane procedure here. So with only one little point where the needle cuts the scanning plane, whereas here in an in-plane procedure we ideally see the whole needle in the scanning plane. What else is important before we start? We need to know how to orientate the marker and the probe. So how to put the probe on the patient to have a good orientation with a needle in the patient and on the ultrasound screen. So as a basic rule, we recommend to orientate the probe marker to our own left eye. And this results in a good orientation so that the left side on the screen is in fact also the left side of the probe on the patient. This is a general rule. Of course, in some procedures we have exceptions from this. Okay, so marker to the left eye of the examiner. Let's look on some ultrasound guided interventions. So we put the probe on the patient, take a needle and puncture the skin, and as it happens to be, the needle gets behind the scanning plane, and so we create a hematoma, and we withdraw the needle, get the second hematoma, try again, get a third hematoma. So this is a situation that, to be honest, happens again and again. So what was wrong here? So ultrasound as such doesn't really improve anything. So in this case, there was no needle tip control. So remember, never lose your needle tip. And for this, we need methods how to actually achieve this. Let's go over some basic probe handling methods. So first of all, in an out-of-plane procedure, we recommend to direct the bevel of the needle towards the probe. The reason is that once the needle gets into the scanning plane, the bevel of the needle creates a good reflection of the sound waves back to the probe. Whereas when you direct the bevel downwards, or if you insert the needle too deeply, then you will have the same conditions for the sound reflection. So part of the sound is being reflected away from the probe, so you won't have a good ultrasound image. So bevel up is important in ultrasound in out-of-plane procedures. Let's look at in-plane procedures. So whenever it is possible, we try to have a parallel needle path in relation to the footprint. So this again creates good reflections of the sound waves back to the probe, and of course in this case the bevel is directed towards the probe too. And this is possible, let's say, in distal sciatic nerve blocks or in TAP blocks too, but we may have anatomical situations where this is difficult. So the angle of the needle is a little steeper, or in vascular axis here in a subclavian axis, there is no option to have this parallel needle path in relation to the footprint. So what do? As a very simple method, we can try to work with our probe. So this is probe handling again. This is the situation. So most of the sound energy is being reflected away from the probe. So what we try to do whenever it is possible anatomically, we slightly put emphasis on one corner of the probe to have a more parallel course of the needle in relation to the footprint, and hence we get better sound reflection. And this method is also available as a software solution of some manufacturers, which we see here. So normally we believe that the sound wave actually travels in a perpendicular direction from the footprint to into the tissue, but we can actually tell the piezo crystals to angulate and to send the sound wave in a specific angle in relation to the footprint, and this is shown here. So you see this line with the little points, and this is actually the direction of the sound waves, which are directed towards a target structure. So we have the probe sitting on top of the ultrasound image here, and now the sound travels onto this catheter and therefore creates excellent sound reflections back to the probe. And this is shown here in a pleural catheter. And but there is one thing you got to keep in mind, because beyond this line with the little dots, the image isn't as good as inside this field. And the reason is that not many piezos create the B-mode image in this area. So whenever you use this software solution, you got to keep in mind not to have your target structure outside of this field. So just don't go here, because visibility of your needle tip will be worse than not having this mode on. Let's talk about hardware solutions. Of course, we all know echogenic needles, and they have got these little cornerstones inside that create a better reflection despite very steep angles. And this is what you can see here. You see a normal needle which actually goes in a quite shallow angle, and the ultrasound needle is inserted much steeper and creates a much brighter signal. And on the second image, you see a very steep angle on the ultrasound needle side, and on the other side, you only see a slight shadow. So there are no reflections of the needle shaft back to the probe, but because the needle is perfectly placed in the center of the scanning plane, it creates a shadow below the needle. So you only have an indirect vision of this needle. So whenever you have very steep puncture angles, or you work very close to vulnerable structures like the pleura, why not using an echogenic needle? As an example, we present a vascular axis of the axillary vein or the subclavian vein. So what you see here is the normal sonoanatomy. So on the medial side, we look at the vein with the typical double pulsation, and lateral from this we have the subclavian artery. And again, lateral, we see structures, more echogenic structures, which represent the brachial plexus. And on the other side, you see the pleura with some lung sliding, and under the plexus structures, you see a little bit of a bone shadow. This is the rib. However, we only use this ultrasound image as a general anatomical orientation, so we want to do the puncture in long axis. So for this, we rotate the probe. We deliberately place the clavicle on the image, so it's just under the pictogram, or under the body marker. And now we've got the subclavian vein in long axis, and under the vein we've got the first rib, and then we've got pleura and the second rib. And as we know that the artery is lateral to the vein, we just check it to be certain, to be also safe for the patient. Check the artery, and in bad scanning conditions, we also may place the pulse wave Doppler inside here and go back to the vein. Take an ultrasound needle because it's a steep angle, and the direction of the needle is towards the first rib as an additional safety feature, not to cause a pneumothorax. And here again you can see how the guide wire is placed directly into the vessel. So some experienced users, they do not use syringes anymore on the needle, so they pre-position the guide wire inside the needle and then place the needle tip inside the vessel under direct vision, and then insert the guide wire directly. This is quite smart actually, but only for experienced users. What else is available? So on the hardware side, so we have options to have like an in-plane guidance for probes. So there is a little plastic clip which we connect to the probe. Then we have a sterile cover, and on the lateral side of the probe we've got this little device that keeps the needle inside the scanning plane only for in-plane procedures. So this is the result. So it kind of prevents on the one hand the lateral displacement of the needle in relation to the scanning plane, and also it prevents the rotation error, so that the needle is not in the same direction as the scanning plane. So we show this device again on a subclavian vein puncture here. So the needle is inserted, and you see here that the needle is just slightly too short. So we move the probe away a tiny little bit until we safely get into the vessel. And here you see the technique how to pre-position the guide wire and very cautiously insert it into the vessel. And this is something we would really recommend you to do. This is a guide wire control. So because of the material of the guide wire, we have very, very good reflections. And so it really takes only a few seconds, and then you are certain where the guide wire is in. You can do this in short axis as just shown, and also you can rotate the probe and see it in long axis. Okay, now we've presented some probe handling techniques on how to improve needle tip control. We have presented some software solutions, some hardware solutions, but now we're coming to to the most important thing, the needle navigation techniques, which you can use in any case, whether you have any hardware or software assistance or not. So we have kind of divided these methods into those for beginners. So we talk about angle navigation and a walk-down technique with angle adjustment. And for more advanced users, we talk about the walk-down technique with probe alignment. And at the end, the smartest and, as we believe, the safest technique is walk-down technique with probe alignment and probe rotation. So let's go over this. Angle navigation is a rough orientation on how to navigate the needle in the patient. So let's go over in an example. So we place the probe on the patient, and the probe sits on the patient in a perpendicular angle on the skin. So we try to find out how deep is our target structure. And we look on the ultrasound image and we see it here. So we aim for the 12 o'clock position of the target structure, and we read the depth on the lateral side of the ultrasound image. So we take this depth, which is roughly 1 centimeter in this case, and we take the same distance away from the probe. So we don't talk about distance from the plastic cover of the probe. We talk about the distance where the scanning plane actually sits on the footprint. So by this, we create a rectangle, and then we penetrate the skin, use 45 degrees, and then we insert the needle. And in theory, we actually get into the scanning plane with the needle tip just at the 12 o'clock position. And then you can puncture your target structure. However, this method is somewhat unsafe. Why? Because having all the correct angles is not very easy. So using a steeper angle, so let's say instead of 45 degrees, you were using 50 degrees or 60 degrees, you would actually penetrate a target structure before you have even seen the needle tip into in the scanning plane. So this might be dangerous. And on the other hand, using like a 40 or 35 degree angle, you will reach the scanning plane before you are in the 12 o'clock position. So you may get the needle tip behind the scanning plane, and this is not wanted. So this is a method which is suitable for superficial structures like in vascular access, so where you want to actually penetrate the target structure anyway. But we wouldn't recommend it to use in nerve blocks. So we show you an example. This is a vascular access in a femoral artery on the left side. So you see in the ultrasound film that there is some tissue movement in the 12 o'clock position right now, and then you see the needle tip being inserted into the artery, and then here again you see the guide wire being inserted on the spot, so it was pre-positioned. So we look at it again, you see the motion of the tissue, you see the needle tip and the guide wire. So it's a good method. However, as we said, rather use it for superficial structures and for vascular access. So in deep structures, it is quite easy to understand that the errors of using the wrong angles actually get greater and greater. So what methods do we have to improve this situation? Let's have a look on the walk-down technique with angle adjustment, which was actually published in 2006 already. In this case, we place the probe on the patient again, as we always do, and then we insert the needle in a very shallow angle. So on purpose, we want to get into the scanning plane in a distance to the target structure. So first of all, we want to identify the needle tip. This is what we see on the ultrasound clip on a IJ axis. So we see the needle tip in the sternocleidomastoid muscle. And then we withdraw the needle and we adjust the angle to a steeper angle, insert the needle again until we get the first reflex of the needle tip in the scanning plane. So have a look here. So the needle tip slowly approaches stepwise the 12 o'clock position of the target structure. So you may do this again. You may do it 2, 3, or 4 times, whatever is needed, and until you are on the 12 o'clock position, and then you see how the needle tip sits on top of the vessel with the largest diameter just under the needle tip, and then you can put the needle in. Here again, there might be some disadvantages because you've got quite a lot of needle passes. So especially in patients on the ICU with a lot of heparin or with coagulation abnormalities, you may not want to have many needle passes. So to improve this, we have another technique whenever anatomically possible. So we need some anatomical space for the probe to actually be moved over the patient. So the angle of needle insertion is basically the same, aiming on an early identification of the needle tip very close to the probe. So when the first reflex occurs, we stop the needle, move the probe, forward the needle, stop again, move the probe like here, and insert the needle a little more until we get to the 12 o'clock position. And then we can puncture the vessel. So this is a stepwise approach where either the needle moves or the probe. So this is a very important information. So don't move both at the same time. So either the needle or the probe. Let's have a look at this in a different way, in a nerve block animation. So the needle tip is in the scanning plane, and we stop the needle, we move the probe just slightly, very tiny little walk down maneuvers. We insert the needle again to get another needle tip reflex on the ultrasound screen, and we do this again and again until we approach the nerve. And now we look from a different angle in the scanning plane now. So tiny little maneuvers once we get very close to the target structure, and now we can inject the local anesthetic. However, shown here, we for didactic reasons we have chosen the 12 o'clock position, but usually in nerve blocks we don't want the 12 o'clock position, so we want to have a tangential needle pass to the 9 o'clock or the 3 o'clock position in order not to accidentally get into the nerve. But this method is certainly very good for nerve blocks in general. So coming to the last procedure, where we think it is the safest and the best and the one you will have most fun with. So this is the walk down technique with probe alignment and probe rotation at the very end of this procedure. So the beginning is exactly the same like in the method shown before. So we just show the last step here on how to get to the 12 o'clock position. And now you don't keep on going with the needle and complete the procedure. First of all, you rotate the probe. So we had a short axis view before and an out-of-plane needle approach, and now we get through the probe rotation an in-plane picture of the needle and a long axis picture of the anatomical structure. And then we can insert the needle under full vision, and you see this on the ultrasound image here. IJ puncture. You also can see that very easily you get kissing walls, and you may approach to the posterior wall, which you only see that well in plane and long axis procedures. And again, here you may insert the guide wire, either with pre-positioning, or you may, as most of us are probably used to, we may use a syringe and do some aspiration and then insert the guide wire. But why don't you look at the guide wire while you insert it, because we all know the case that for some reason we get blood out of the vessel, but then can't insert the guide wire. So with ultrasound, you may easily visualize what the problem is. So either it is not inside the vessel, or it is actually gone through the posterior wall, or third option, something in the vessel is obstructing the guide wire, like thrombosis or something. Okay, let's have a look on nerve blocks with the same method. So we show again the last walk down steps, in this case again to the 12 o'clock position, and then in a little distance we rotate the probe so that the last step towards the vulnerable nerve structure is very well controlled. Okay, so what else is an issue? Look at this. So especially in nerve blocks, we have a situation that the visibility of nerves varies a lot and is dependent on the angle of inclination. So look at this. So we have we put the probe on the nerve, and now the reflection is not very good because it's not a perpendicular angle on the course of the nerve. So we slightly tilt the probe to get a very good image on the ultrasound screen. And then using a short axis and in-plane approach, it may be an issue that for some reason it happens that the needle is not in the scanning plane. So what do? Do you move the needle, or what do you do? So if you tilt the probe, you get you may lose your image. So what you do instead, you do a little parallel sliding of the probe, keeping the angle. So you hopefully get a good image and a good identification of the needle for a safe approach towards the nerve. And also in in-plane procedures, you may have a rotation error so that the needle path is not perfectly aligned with the scanning plane. And you also, of course, then have to correct this error by probe rotation. Another thing is the inspection of guide wire position, which we were talking about before already. And this is a method that only takes a few seconds and gives you a lot more confidence, especially in difficult cases, in cases on ICU with coagulation abnormalities in patients where you need to insert large catheters. So as shown here, you see two hyperechogenic dots traveling through the sternocleidomastoid muscle into the IJ. And of course you can do this in short axis as shown here, or also in long axis. And then you may proceed with your dilator and put the catheter in. And this is how we end up having done successful procedures. So we end with the recording here and continue with the recording of the three of us. Thank you.
As a summary of our useful informations about safe needle tip control and navigation techniques, we created a poster. The bad news is it's just available in German language.
But our textbook is available in English and of course in German, and you can find it on our webpage.
Coming back to the very beginning of our presentation, where we were talking about the three pillars, so the preconditions of safe and successful ultrasound-guided interventions, which were probe maneuvers, sonoanatomy, and needle tip control, we would like to add two more pillars, so with 5 at the end. So we need sustainable teaching concepts, and at the end we need to practice a lot to achieve more. Thank you for listening.